Good morning, good evening, depending on which part of the world you are in. I'm Dr. Shabnam Daskar, a functional medicine specialist. Today, I have the honor and privilege of having a great person on as a guest on this video. So, my guest today is Dr. Vikas Agarwal. Dr. Agarwal is Professor Clinical Immunology and Rheumatology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, in India. For those of you who don't know, this is a very prestigious academic institute in India. And additionally, Dr. Agarwal is the editor-in-chief of the Indian Journal of Rheumatology. The Indian Journal of Rheumatology is a peer-reviewed and indexed journal. So that's a very respectable journal. And thank you, Dr. Agarwal, for being my guest today. What we will discuss today is COVID-19 from a rheumatologist's perspective. Dr. Agarwal has published a few papers recently, so we will, and as much as time permits, we'll go over some of them. So, Dr. Agarwal, will you say some words of introduction about yourself?
A very good morning, good evening to all the viewers, listeners, and thank you being very generous with the introduction about myself. And that is all what I can say. I can't add anything more to that. Thank you being so generous about it.
Thank you, Dr. Agarwal. You're being very humble. So I'm going to share a screen so that I want to share a PowerPoint. So this is about Dr. Agarwal and me. So this is the paper, Dr. Agarwal, about which I reached out to you because this was very interesting. So this is Management of Rheumatic Diseases in the Time of COVID-19 Pandemic, Perspectives of Rheumatology Practitioners from India. Dr. Agarwal, will you just briefly describe who these doctors were? And you obviously reached out to them through an internet online survey form, right?
Yeah. So I'll narrate you actually how it actually started.
Mm-hmm.
We were busy with our COVID ward duties because in our hospital we have to, this part of the world is seeing a lot of COVID cases, and ours being a government tertiary care hospital has been converted into a COVID hospital. So we all are having our duty rosters as per the schedule given to us by the administration. So one of my junior colleagues, who is the first author of this paper, Dr. Latika, the
Mm-hmm.
very one fine morning she asked me, "Sir, what to do? Patients are coming for infusions of cyclophosphamide or rituximab. What should we do? Should we really defer the infusions for the time being, or what not to do?" So I was not sure what to do actually with these patients. So I said, "Ki Latika, I'm really not too sure because I will be very sort of skeptical of giving immunosuppression at the peak of this COVID pandemic going on right now. And in India, social distancing and all the measures of hygiene and mask, they don't work because we live in a very crowded atmosphere, crowded conditions. So everybody is likely to be exposed at some point or the other. And I was really scared for my patients. Then she asked me a few more questions, for which again I was not very sure, given the experience I have of 25 years of this specialty and seeing patients day in, day out. And I see almost 500 patients every week for last so many years. Despite that, I was not very sure. So we thought, okay, let's design a questionnaire and find out what all our rheumatology colleagues feel. Are they sort of feeling the same kind of a depression that I am feeling with your questions right now, or they are more wiser than me, and let's have a consensus how to go about, because this is going to last for many months. And this was in the middle of March actually, when the epidemic was just picking up in India. March, India has hardly less than 100 cases at that point in time. So we designed this 31 questionnaire, and Latika being very friendly with Survey Monkey, and she said she has sort of has worked in Survey Monkeys earlier for her few more surveys. She said, I can design the questionnaire and then just pass it on to the members of Indian Rheumatology Association. Now, India, despite having a population of 1.3 billions or more, have got a very limited number of rheumatologists in this country. if we look at the Indian Rheumatology Association, the members are not more than 1,300. And we really don't know how many of these 1,300 are actually full-time practicing as a rheumatologist, because not many are actually trained and they just have an interest and they just love to practice rheumatology, or they practice some rheumatology and they are members of us. So since I am editor of the journal and we distribute journals to all the members of the Indian Rheumatology Association, so we thought, okay, we'll send it out to the members, and I have all their phone numbers and their WhatsApp numbers and email IDs. So we sent the surveys to 161 members of Indian Rheumatology Association, thinking that at least some of them should respond. We were actually sort of thinking that let's have a response quickly, because we need to know how to change our practice for coming days or weeks. And patients were every day knocking our phone calls or video calls, sir, what to do, because they cannot enter the hospital without a COVID test. So we gave them 1 week time from 22nd to 28th of March to respond to this questionnaire. Luckily, I say that almost 221, more than one-fourth, responded to the call. They filled the surveys completely, and from there we got this information. So, like what I was thinking initially, I was having difficulty in answering Latika's question, what to do with immunosuppression. I really find that the same was the scenario for most of our rheumatology colleagues in India. They were also having a lot of apprehension about the use of immunosuppression. Actually, I must say that the very first figure which shows the COVID-19 outbreak has led you to reduce the dose of uh, uh, conventional synthetic disease modifying drugs. Actually, this is wrong. Actually, this is a biological DMARD question, figure related to that. And it
Uh,
shows almost
okay.
40. We'll send a correction to the journal.
Oh,
Luckily,
I'm sorry about that, Dr. Agarwal. So, what you are saying is this: the
yeah,
chart on top
top.
should be actually the BDMARDs, right?
Yeah, it is
And
BD
this,
marks.
okay, and this one should be
And
the
this should be the
CSDMARDs. Okay,
absolutely right, madam.
okay. So
So,
anyway,
anyway,
even if it's not correct, so what did you exactly find? What were rheumatologists thinking of doing? And another important factor I want to mention, Dr. Agarwal, is you said this survey was done in March. That is extremely
yes,
relevant about some other questions on HCQS when we come to that later on.
absolutely, madam. So, what we realized that almost 47.4% of the respondents, they were reducing the dose of biological DMARDs, and especially their concerns was more for rituximab. They were very scared of using rituximab. As far as anti-TNFs were concerned, they were continuing, especially for angst cases or rheumatoid arthritis cases, and followed by there was a lot of concern in not using cyclophosphamide, because this is a potent immunosuppressive medication which is used especially in patients with lupus or lupus nephritis or myositis, and certain patients with cyclophosphamide who are having severe interstitial lung disease. So, so these were the concerns which were actually picked up by the survey. Yes, there was a lot of issues and a lot of apprehension about the use of immunosuppression in form of biological DMARDs, immunosuppressive drugs in form of cyclophosphamide, and also targeted synthetic disease-modifying drugs like jackinibs. The issue was that there was a theoretical rationale of using jackinibs to treat COVID-19, but when you look at the rationale also, you realize that the dose required for inhibiting the viral replication will be very high. And that dose itself is likely to cause much more toxicity. And that is what is there in the minds of most of the rheumatologists of our country as well. As far as conventional synthetic disease modifying drugs like methotrexate or leflunomide or sulfasalazine was concerned, most of them were thinking that these are not going to cause much problem, not predispose individuals to uh, catch infection easily or early or make them susceptible, or to have an adverse event because of infection, because of these conventional synthetic disease modifying drugs. Interestingly, most of the rheumatologists felt yes, hydroxychloroquine is a drug which can be used to treat as well as can be used for prophylaxis of COVID infection. And they said even when we see some case who has got some arthralgias, which is even non-specific, even then they will indicate to use hydroxychloroquine, especially during this period of pandemic, thinking that it may help patient to at least face the COVID pneumonia much more sort of in a better way as compared to had it been that patient is not receiving any hydroxychloroquine. So this was the belief in India in March actually. And yes, this is, you can see that almost
Yes.
two-thirds
So
responded by giving
I have,
hydroxychloroquine.
yes, I have just, this is the portion that I have just magnified
Highlighted.
on this slide.
Yes. Yeah.
So given that of the respondents, 66% were more inclined to initiate hydroxychloroquine in patients with borderline indications.
Yeah.
Now, the other thing that you commented on the paper, which was extremely relevant, I thought, was, I'm just going to minimize this one. So this is, I'm quoting directly from your paper. There was unanimous agreement on use of HCQS. This may be attributed to its safety profile, greater in vitro efficacy against COVID-19, and greater experience with HCQ as rheumatologists. And however, caution is needed as reports of toxicity have emerged with the use of prophylaxis. That the bold is my I have added that. So
Yes.
one thing, Dr. Agarwal, I wanted to ask is, again, talking to many people, these are just off the cuff comments from rheumatologists or people who have been using hydroxychloroquine extensively. They have been telling me, oh, HCQ is very safe. Now, the thing is, this is the question I asked you as well. So,
Yes.
what the biggest question that, again, you have also mentioned it in your paper, is the caution of, the reports of toxicity which have emerged. Now, the toxicities, most of them have shown heart arrhythmia. It was prolonged QT interval. And again, I'm not a cardiologist. But my question is, supposing a patient had an arrhythmia on HCQ and they were recommended the HCQ by a rheumatologist in the past, it is
Yes.
quite unlikely that they would go to a rheumatologist with a problem of a prolonged QT, because one of the things that happens with that is a sudden cardiac death. And sudden cardiac death is also commoner in people with diabetes. So, Dr. Agarwal, since diabetes is so common in India, this is kind of like a double whammy, right? So, am I
Absolutely.
right in thinking that we don't have enough information about the safety? Or is it that, because I have checked the data, I didn't find a lot of data, because the other thing is we don't have a lot of good records which will tell us, okay, this patient was on HCQ, but died at this time, and we don't even have the autopsy reports. So I'd like to hear what you would say. Is it an absence of evidence? Is, as in our world we say, an absence of evidence does not mean evidence of absence. So I'd
Yes.
like to hear what you, because as rheumatologists, you all have extensive experience of using HCQ.
Absolutely. I'll give you a perspective. Like I'm in practice for more than 25 years now, and we are using hydroxychloroquine right, left, and center. Almost all the patients of SLE, they will be on hydroxychloroquine unless they had some kind of a serious adverse event earlier. Or patients of rheumatoid arthritis who are receiving methotrexate, we generally tend to use hydroxychloroquine simultaneously because we had seen it reduces its side effect of methotrexate and adds to the efficacy also. If you really ask me, in last 25 years, had we faced any problem with the long QT interval? I will say I cannot recollect even single instance of prolonged QT changes on ECG in any of the cases. And we have more than 2,000 patients of active lupus in our follow-up at our center. I'm just talking of a single center. And we have more than 10,000 patients of rheumatoid arthritis who are following with us. Not less, I think even more than 6,000 patients must be getting hydroxychloroquine even today. So, and we have this experience over last so many years. And we discuss this amongst our rheumatology colleagues also. on WhatsApp group when these evidences came in form of toxicity or no efficacy of hydroxychloroquine. Extensively, we have debated on WhatsApp group. It is not being published, but almost all of us are unanimous in our viewpoint. They have never seen any cardiac toxicity. Now, the scenario may be very different when we talk of COVID pneumonia, because COVID, when it causes cytokine storm, it can cause myocarditis, and we still don't know what could be the direct influence of the viral infection on the heart or the endocardium of the heart or the other factors. So it could be that in patients who of COVID pneumonia who are having myocarditis, the drug may be causing some kind of arrhythmias. But we need to look at the dose, what they were getting. Generally, most of the rheumatologists in our country, they don't go beyond 5 milligram per kilogram per day dose. But when you look at some of the protocols of US, you tend to see a lot higher doses of hydroxychloroquine or chloroquine being given to patients to treat COVID pneumonia also. So it could be that higher doses can cause. And if you look at the pharmacological aspect, it is very well mentioned in the pharmacological textbook. When you use higher dose, then you are likely to have arrhythmias or cardiac toxicity of this drug. So I think that should answer the question. But yes, if you really say whether we have some evidences, because none of us felt we need to actually explore this aspect also. The cardiac toxicity of hydroxychloroquine in routine rheumatological patients, because none of them had this kind of an experience that they had had some patient who has died suddenly, or some, when you say that patient will go to cardiologist, but they will come back to us to bang us. Look, doctor, your drug has actually caused the problem.
Yeah, that is true. Dr. Agarwal, thank you very much. Just one more comment, and I know without data you can only give an opinion.
Yes,
It cannot be
yes,
it's speculative. Would you
yes.
think that there is a difference because of the genetics of in people in India, that the response could be different to HCQ in Indians versus people in other ethnicities? I know I'm asking you to speculate because we
No,
don't have the data.
yeah, we don't have, but the issue is like, I will give you one example of that. It could be because if you see methotrexate induced nodulosis, that is, I'm talking of methotrexate, I'm not talking of
Mhm.
hydroxychloroquine. It is having some kind of HLA associations in the Caucasian population, but it
Yes.
has got hardly, and that kind of a HLA are not seen in our population. We had done this kind of a study at our center.
Mhm.
HLA 401, HLA DRB 0401 and 404 are very well known to be associated with methotrexate-induced nodulosis, but they are hardly seen in India. And we do see sometimes that some of our patients do get methotrexate-induced nodulosis also. For hydroxychloroquine, difficult for me to say because we don't have any data and its HLA associations or toxicity with HLA associations. We don't know,
Thank you.
but it
So
could be.
it
But
could be.
I cannot say yes or I cannot say no
Yes,
for
I
your.
know. I asked
Yeah,
you to speculate actually,
yeah,
not
yeah, yeah.
based on data. So
50-50.
thank you, Dr. Agarwal. So one more, just a few comments on HCQS, because
Yes,
number one is this drug is very cheap. So
yes,
recently, as many of our listeners may be aware, that two papers were retracted. One was in the Lancet, one was in the New England Journal of
NEJM, yes,
Medicine.
yes,
Both those papers were retracted because now the thing is, there's a lot of criticism, a lot of conversations going on everywhere about how they did it wrong and how could two such well-respected journals have gotten it all wrong. What I was looking at is the fact that the authors had retracted the journals. It was not the journal who had to retract them. Number one. Number two, the biggest challenge was with the data set. It was not it was like some 600 different hospitals all over the world, and I wondered how they had collaborated in such a short span of time. So
yeah,
the problem with those studies, again, it is important to understand the difference, because we should not dismiss HCQS right now. That is my point. Because what if it has benefits? So what those papers, both of them, many of you may have read those papers, many of you may not have read. Both those papers suggested that HCQ was not beneficial for people with COVID-19, and it was also not beneficial as a prophylactic. However,
Yes,
the point is a good, information will come from good data. So the data sets they had used were corrupt. They were not absolutely watertight data sets. And in fact, I think the authors couldn't even, provide all the clarifications about the data. So my point is, I think Dr. Agarwal, you will know much better than me. There are lots of studies still ongoing about HCQ. And would you suggest that people should just wait for better quality studies to come out before deciding either way? Am I right? Because HCQ is like, it's low cost, and if it's really beneficial, why not? Because COVID is not going to go away, right? So Dr. Agarwal, what would you
absolutely.
say about that?
Yeah, absolutely bang on point, madam. The HCQ data in the two big journals, which has now been retracted, should not be given any importance. I'm not saying that they were right or wrong. Let's see the data which is coming up and gets published. Number two, WHO has withhold the trial of hydroxychloroquine when these two papers were published, but now they have restarted the trials.
Mm-hmm.
So that itself suggests that yes, there is food for thought that hydroxychloroquine is going to work. And being a rheumatologist and immunologist, we have read through some of the basic papers of chloroquine-induced prevention of infection by COVID, and we had seen that in vivo E6 cell lines, if you pre-treat these cells with chloroquine for a few hours and then you infect them with the COVID virus, it hardly causes any infection. There is hardly any detection of the antigen of the virus. And even if you pre-infect the E6 cells, Vero E6 cells with the virus, and within 1 to 4 or 5 hours you start or you add chloroquine to the media, it still prevents replication of the virus. It decreases the antigen of the virus, viral load. So clearly, in vitro, there is a definite evidence to suggest that chloroquine acts on the virus and doesn't allow its replication.
So
And it's a safe
thank you.
drug. Yeah,
Yeah,
and we have great experience with the molecule. So till we find a
yeah.
absolute negative study, we should not disown
Dismiss.
hydroxychloroquine in treatment of COVID.
Thank you, Dr. Agarwal. So just clarifying, because Dr. Agarwal, many people may not be able to differentiate. So what Dr. Agarwal is saying, in vitro studies, that means
Yeah.
studies on cells in a petri dish and not in
Yes.
clinical trials.
Okay.
Chloroquine has shown very good benefits. And another additional benefit, Dr. Agarwal, I'd like to mention, because there's so many people who have diabetes in India, is the beneficial effects on diabetes of HCQ, that, and also in the lipid profile. And you must be seeing it every day in your practice, right?
Absolutely.
So again, we've been hearing a lot about the cytokine storm, and Dr. Agarwal, most of us are not immunologists. So
Yeah.
what would you like, just a general kind of a non rheumatologist, non immunologist doctors, what should they know about a cytokine storm? And then I'll come to the next part of the clinical application of it. And the other term that you mentioned in one of your papers, I'll have to really look at it because it's a mouthful: hemophagocytic lymphohistiocytosis. This is
Cytosis.
the secondary one. The primary one is a genetic problem. That is not what we are going to talk about. So, Dr. Agarwal, I'll let you explain the cytokine storm and the secondary HLH.
Yeah, absolutely. So what happens when the virus is actually entering the body? So it enters through the nasal route and through your uh, uh, epithelium of the respiratory tract or the lung epithelial cells, and also the endothelium of the blood vessels and some intestinal epithelial cells. So this is the whole area through which the virus is entering your body. Now, once virus enters the body, in a very small percentage of individuals who are getting this infection, they will develop a condition called as cytokine storm, where because of this viral infection, the immune cells of the host or the person who is getting the infection becomes hyperactivated, meaning that these inflammatory cells causes release of certain cytokines. And generally what we are talking about is the cytokine like GM-CSF, which is also called as granulocyte monocyte colony stimulating factor, or IL-1, IL-6, interferon. There are a whole list of tumor necrosis factors. These all cytokines, they generally help to kill the infection or kill the pathogen. But here what is happening is that it is causing dysregulated release of these cytokines in a very large number, as if there is become some kind of a storm in the body. These cytokines, by virtue, they target the pathogens and they have got some adverse effect on the pathogen. But here, because of their sheer large volume, they start destroying the host's uh, organ system, or they go into the systemic circulation and go into kidney, heart, lung, brain, and other parts of the body and cause the organ dysfunction, which manifest in form of various manifestations like renal shutdown, patient having hypoxemia, lung edema, not able to breathe. The myocardium becomes inflamed, causing myocarditis. Heart is not able to pump the blood effectively. And this is the major killer in some of these patients of COVID pneumonia. In fact, whatever autopsy studies are available, but there are very limited number of autopsy studies are available till today. They have shown that lot of lung parenchyma is inflamed. The vessels are actually having lot of thrombosis. The microclots in the blood vessels are formed. So this is all part and parcel of cytokine storm. Now, cytokine storm is a very generic term we use. It basically, you can say it is a cytokine storm, and some of times you can refer it to as macrophage activation syndrome. Generally, this term is used when patients of rheumatic diseases, they develop cytokine storm following some infection, either bacterial or viral, or in other conditions, it is called as secondary hemophagocytic lymphohistiocytosis. They all tend to mean the same, though they may have some differences in their clinical manifestations and sort of outcome depending on what kind of interventions are being introduced. But they are all part and parcel of cytokine storm. Now, for COVID, this becomes very interesting and very important also, because when actually why this is happening, if you can allow me, if I can go back to some of the very basic science behind this cytokine storm. What happens when the virus is entering the body? As soon as virus enters any cell, virus is recognized by two sort of sensors in one's cytoplasm of the cell. These two sensors can be termed as TLRs, that is, uh, it is present in the endosomes, or it could be uh, RIG or MDA5, which are present in the cytosol itself. Once they recognize these RNA of the virus, they start secreting interferon alpha, type 1 interferon, which is either interferon alpha or beta. Now this interferon alpha and beta leads to some kind of signaling inside the cell, and this cell starts secreting lot of interferons. And these interferons and other cytokines, they in an autocrine loop signal back to the cell itself. And now when this second signal is coming to the cell itself, it secretes now type 3 interferon, which is in form of interferon gamma. Now, interferon gamma is very important to kill the virus or any intracellular pathogen. Now, here what is happening is that somehow virus has become so clever, it has got some defective mechanism in some individuals who are either genetically susceptible or somehow predisposed. They don't secrete lot of type 1 interferons in first place. So the virus proliferate in these cells. When the virus is proliferating, these cells are getting damaged. And when the cells are getting damaged, they are releasing a lot of DAMPs, which are called as damage associated molecular patterns. And these DAMPs bring in a lot of inflammatory cells in the local environment. So, and these local cells, they become hyperactivated and release a lot of cytokine. That is how this cytokine storm is happening in cases of COVID. And this is very well documented for the previous coronavirus as well as Middle East respiratory virus also. So I've
Yes.
taken that pathogenesis from there and try to put it in here in this COVID pneumonia.
Mhm.
But the next question is, okay, patient is developing this kind of a feature, how to recognize it? They will have fever.
Uh, Dr. Dr. Agarwal, I'm just going to interrupt you for 1 minute. So a
Yeah.
cytokine storm and a secondary HLH, do they clinically look very similar? And is it important to differentiate, or you can treat them anyway without even differentiating?
Some may say they are almost synonymous. Some may say they are not synonymous. Cytokine storm is a bit early stage, and the hemophagocytic lymphohistiocytic stage is a bit a late stage or a well-established stage of the cytokine storm.
I'm sorry about my phone. Sorry. Yeah.
No problem. So they look like the same actually. But yes, the basic fundamental pathogenesis remains the same. It is release of lot of cytokines, which is causing damage to the host organ systems.
Okay, thank you. So, from a clinician standpoint, it may not be necessary to differentiate the two because it will not
Absolutely.
change the management a whole lot.
Yeah.
So, next
Yeah.
question that you were going back to what you were saying: can a cytokine storm be predicted? So, and
Absolutely.
another question, Dr. Agarwal, is what I understand, and I'm not in the COVID frontline, or I'm not even an immunologist. There is a very short span of time between a cytokine storm starting and a multi-organ failure happening. So, in your
Yes.
experience, what would you say? Again, a ballpark figure. I know that you don't have any papers right now to talk about that. What kind of a timeline are people looking at?
Yeah. So this I will just take a corollary from the other conditions like macrophage activation syndrome, in which are very well known in rheumatic diseases. There you see that the toxicity of CD8 cells or natural killer cells is become less, and the hyperactivated cells, all the other T cell lineages, monocyte macrophages, they remain high and they keep on secreting a lot of cytokines. So yes, this can be predicted by at least 1 or 2 days in advance of actual organ dysfunction happening. And this is the main target actually. If you can pick up patients early and treat them early, probably you can reduce the morbidity and mortality. So
Thank you.
if you tend
So,
to see patient is having continuous fever,
hmm,
if you patient tend to develop seizures, they throw seizures, you can think in terms of patient develop a sudden cytopenias, like earlier counts were normal or high and now it is going down. Sudden normalization of your ESR, a rise in any of these four, any two of these four factors should alert a clinician. CRP, ferritin, LDH, and D dimer.
okay.
If you see that any of these four, any two of these four are actually risen more than 3 times of the normal values, upper limit of the normal, you suspect that patient is heading towards your cytokine storm. Clinically, you can suspect this, that patient developing hypoxemia, that their saturation is going below 93%, or their PaO2 or FiO2 ratio is less than 300. The respiratory rate has gone up suddenly by more than 4 per minute. Suppose it was 20 and now it has become 24 or more. You start suspecting that patient might be heading towards cytokine
So,
storm. And as you have mentioned here, patients can develop thrombocytopenia, anemia, they can develop leukopenia or lymphopenia. Generally, transaminases are high when you have a viral infection, so they don't give you much idea whether patient is heading towards a cytokine storm or not. Interleukins or cytokines, other cytokines like TNF alpha are not available in routine clinical practice, but CRP, D dimer, ESR, LDH, and ferritin, these are almost universally available all over the world. So if somebody can focus on these four parameters along with the counts and hemogram, I think you can pick up cases of cytokine storm at least 24 to 48 hours early, and patient start when the patient start having some kind of an organ dysfunction.
thank you, Dr. Agarwal. And I will actually ask you to repeat that again because most of that I don't have on my slide.
Yeah.
So, because that is, I think, extremely valuable information because people have that 1 to 2 days window
Yeah.
to change their clinical management. I'm coming to that later on. Again, I'm not on the COVID front line or anything, but I think it will help a lot of my colleagues who are dealing with this. So, Dr. Agarwal, at the thing of asking you to repeat, you
Yeah.
mentioned that one is oxygen saturation, and
Yes.
I'm writing down so that I can add all that into the bottom of the video so that people can use this information. Of course, CRP, these are easily available. And then you said ferritin. Now, I don't think we'll have time, but this is the hyperferritinemia that I would have loved to talk about in autoimmunity, but that's for another time. Then D-dimer. These are all available in every hospital in India, I think.
Yes.
And you mentioned LDH, right?
Yes. Yes.
And respiratory rate sorry,
24.
more than 24. And so have I missed out anything else?
Yes. PaO2,
Okay.
FiO2 ratio of less than 300.
Okay, FiO2 ratio of less than 300.
Yeah.
And you said also leukocytosis, I think. Am I right?
Leukopenia.
Leukopenia. Yeah.
Sudden change in the leukocyte count or
Okay.
platelet count.
Okay.
And one more, which I am taking from my rheumatic disease experience, sudden normalization of the ESR.
Okay.
Earlier it was high and now it has become normal.
Okay.
Patient having continuous fever which is not responding to anything, or
Okay.
patient has thrown a seizure.
Okay.
So you can think that this patient is having a cytokine storm.
Okay, so these should be the red flags, sort of, and particularly the
Absolutely.
other given thing is a lot of people who are not used to dealing with emergency situations, doctors have been asked to go into COVID duty. So, thank you, Dr. Agarwal. That's very valuable information. And another information you've already actually probably answered. My question was, what I understand is in a cytokine storm, there are so many interleukins that may be released. So will
Yes.
it, again, I know in India it's probably not available. The test is not available easily, and even if it's available, it's probably quite expensive. Would it be, let us say in an ideal situation, if we had a choice of checking particular ions, would we prioritize some over the others, and will that make a difference in the treatment?
You're talking about the interleukins.
Yes, interleukins.
See, even today, I don't think any. There are some protocols which I had looked at the clinicaltrials.gov,
Hmm.
where almost now 29 trials are there on anti-IL-6, that is a tocilizumab
Yes, you mentioned
for,
that in your paper. That's why I'm
yeah,
bringing it up.
yeah, cytokine storm. So basically, I think only one or two trials have mentioned the estimation of interleukins, but I don't think anybody is routinely doing interleukin levels, and one should not be targeting that also, because we really don't know what is the cutoff level of the interleukins above which we need to suspect cytokine storm, or which will give us much more confidence in diagnosing cytokine storm. And I think this combination of CRP, D-dimer, LDH, and ferritin is good enough in a clinical situation. And see, I'm telling you practically, because I have worn a PPE, how you feel like when you work wearing a PPE. Your efficiency decreases by almost 3/4. You almost work only on your 1/4 of your uh, skills and 1/4 of your performance. So here the everything is limited. Sampling even from patient wearing PPEs is difficult. So, and we need to do tests which are easily available
Yes.
24 hours, which can be collected within, the reports can be collected within 2 to 4 hours. And these, every minute, every second is very crucial when you are suspecting a patient with cytokine storm, if you really want to do some kind of an intervention. Of course, in COVID pneumonia, all the interventions are still experimental as of today, and we have to see what actual outcome is there when we see the results getting published from various studies.
Thank you, Dr. Agarwal. So again, you have already answered that question, because does the treatment change? Yes, it would change. So what is the
Yes.
major difference in the management of cytokine storm in COVID-19 versus someone who's not having a cytokine storm?
Yeah. So this is the major problem which is causing organ dysfunction. And if you look at the sequential organ failure scores, SOFA scores, which is very well looked after in a lot of chronic liver conditions or acute liver conditions or renal conditions, you will realize as there is more and more organ dysfunction happening, the outcome is going to be poorer. And same is the thing which is happening with the cytokine storm. This is the very crux which is causing sequential organ failures and likely to cause morbidity and mortality. So somebody who is not having a cytokine storm is very well likely to recover on its own, or will have very less of morbidity and almost negligible chance of mortality, unless somebody is having more some kind of comorbid conditions which predispose them to some other problems. Otherwise, and this is a major difference, what I feel, by going by my experience of last 3 months working in the COVID unit, that patients who are likely to have a poorer outcome are having some kind of a cytokine storm.
Thank you, Dr. Agarwal. Now, completely far away from cytokine storms,
Yeah.
going to the use of ibuprofen, because as a rheumatologist, many of your patients have pain. So, what is the thing about whether people should continue using ibuprofen or should they switch to something like a paracetamol? And why is that relevant in the COVID-19 situation?
Yeah, I think if you look at our survey data also, most of the rheumatologists, they discarded this myth about the ibuprofen, that ibuprofen causes upregulation of ACE2 receptors, whereby the infection becomes much more severe. This has been put to rest also in last 3 months since the publication of this paper also. And nowadays, all the non-steroidal anti-inflammatory drugs are almost similar. So one can use anything, but as a rheumatologist, I hardly use ibuprofen because this is very short lasting drug and most of our cases are having chronic pains. So even if we have to use a non-steroidal anti-inflammatory drug, we use a drug which has got a long action, like naproxen or something like etoricoxib or others.
Okay,
So, but
thank
if
you.
somebody is comfortable with ibuprofen, they can use it. But remember, all kind of NSAIDs are a problem in a setting of viral infections.
Yes.
So one has to be very, very cautious in usage of NSAIDs. If you can work with paracetamol, fine. Don't use any of the NSAIDs.
Thank you, Dr. Agarwal. And you are saying in relation to viral infections, I would say NSAIDs are problems in any condition. So as little as possible, but then I understand a lot of people have pain. Now, this was
Yeah, but
something interesting that you mentioned in this paper, which you are a co-author on, that
yeah,
many of the COVID-19 symptoms mimic rheumatic syndromes. So would you
absolutely.
say a little bit about that? And that from this will come my next question is, when should doctors reach out to their rheumatology colleagues? Because this is such an uncertain situation and you all have way more experience in dealing with some of these things than other specialties.
Like we have mentioned 6 conditions here, which actually mimic like a rheumatic condition and very commonly seen in our OPD as well as our indoor patients. They have a lot of arthralgias and myalgias. They are non-specific, but they sometimes can be the forerunner of a chronic rheumatic condition, which is likely to evolve in coming days or coming weeks. Myalgias are very common when we see patients with inflammatory myopathies or myositis. Cytopenias can be seen in conditions like lupus or something which is like a complication happening, like macrophage activation syndrome happening in a setting of any rheumatic disease or cytomegalovirus infection or any drug, because we use a lot of immunosuppressive drugs and almost all the immunosuppressive drugs have a potential to suppress the bone marrow also. So one can be called into like see what is the cause of cytopenias in this particular patient. And we are actually called for our emergency units most of times in our hospital. Not the hematologist they call first. They call us first. And when we say, it's not ours, it is hematology, then only they call the hematologist.
So, Dr. Agarwal, you are at a very prestigious academic institution where probably it's not difficult for your colleagues to reach out to you. But as you mentioned at the beginning, there are just about 1,000, 1,200 rheumatologists in India. So what would
Yeah.
someone who doesn't have direct access to a rheumatologist, what could someone like a doctor like that do? Is there any phone consult available just to ask, a second opinion sort of thing from a specialist?
We are not that well organized as far as health infrastructure is concerned in this country.
Mm-hmm.
But if someone is actually coming through someone, if somebody is able to reach us, because hospital numbers are available at the websites of the hospital,
Okay.
and from there they can connect through the telephone exchange to the respective department. And if somebody says, and somebody knows the name of the person whom to contact, exchange people, they do connect us. Whenever we get a call, we try to respond as uh, sort of with all our sort of experience and all our passion to help out the person, because we also understand that in India, with a population of 1.3 billion, there are hardly 1300 rheumatologists. So not everybody can, and our MBBS and MD trainings are not that good as far as rheumatology as a specialty is concerned. But nowadays things are looking better, because over last say 5 years, a lot of other centers have started super specialization in rheumatology, and many young rheumatologists from abroad has come back to India and has settled down. Though they are settling down in the metropolitan cities or large cities, but nowadays at least there are, earlier there were so many states, not even a single rheumatologist was there. Even today there are states where no single rheumatologist is there, but still nowadays people actually know whom to contact and whom to find out. And with new All India Institute of Medical Sciences actually opening in lot many states in India over last say 4 5 years or 6 years, again things have improved. But yes, conditions are far from being what it should be or what it should like be. Uh, but somehow very difficult for even doctors to consult us many times.
Thank you. So the next is, again, before I move on to what you would recommend as an expert opinion for rheumatologists, just two things I wanted to mention, Dr. Agarwal. I'd like your comments on that. One is, given the preliminary few studies that have come out. Now, the caveats are the COVID-19 patients in patients with any autoimmune condition like RA or SLE or multiple sclerosis. We don't have a lot of data available. But going by the early data available, am I right in saying that so far, we haven't found the evidence that having an autoimmune condition would increase their risk beyond what is already there for someone who doesn't have that?
Yeah, but again, we are talking in terms of non-availability of the data.
Yes,
But
yes.
if you really ask me, going by the chats what we had shared with colleagues on WhatsApp and emails, many feel like most of our patients are doing reasonably well. They have not contracted any infection with COVID, and there are few reports which are going to be published in my journal soon, where patients of lupus, they got infected but they recovered soon also.
Yes. So actually, I wanted to give that message of somewhat reassurance to people who have any autoimmune condition, that the usual ones like diabetes, high blood pressure, heart disease, those are there. But just because you have an autoimmune condition, your risk may not be more than what it would be for the other people. But again, all cautions, because this is early data. We don't have enough.
Yes,
So, Dr. Agarwal, what would you suggest to rheumatologists, or there are a lot of other doctors who deal with rheumatology patients? What would be
yes.
your best practice recommendations at this time?
I will say that if they are going to see the patients, because that is another issue actually which is coming up. Physical consultations are not available, and nobody likes to do this kind of practice. I'm sure in your part of the world and many parts of the world also, nobody is actually willing to physically consult a patient.
Mhm.
So we are also into teleconsultations for last 3 months, and what we realized, obviously this is not the condition what we would have liked, but given even telephonic consultations are sufficient. So try to, at least those who cannot come to you or you cannot reach out to them, give them at least some lifeline where they can consult their doctors, and we should be prompt in actually giving responses to our patients, because many times what we have faced on teleconsultations, that the non availability of the drugs, Plus, in India, there are not many companies manufacturing the same molecule. But if you have written a one name and that name drug is not available from that company, patient is not getting it. So we need
Oh,
to be more with the generic of the or write the salt, and we tell our patient that you please take whatever company drug is available. That is one. Some minor problems which have cropped up in teleconsultations where patients have uh, developed some other problem, like somebody developing gastroenteritis or some other infection, which could have some skin infection, which could have been easily treated with oral antibiotics. So these kind of things can be sorted out on teleconsultations. We have adopted a practice because even now Indian government has given guidelines
yes.
and has legalized the teleconsultations. Earlier it was not
Not
legalized.
legal, I know, because I
Yeah.
run my practice with teleconsult.
Oh, great. So then you know better than me, madam,
No,
because
not
we are
really.
very new to teleconsultations. But I think it is helping out patients. And what we have adopted now is we treat patients as if we would have treated them when they have come to us with as for physical consultations. We are nowadays not afraid of even using biological disease modifying drugs, even rituximab or cyclophosphamide. Even if the condition is actually necessitating the use of cyclophosphamide, we are using it. And we are starting the conventional synthetic disease modifying drugs right, left, and center. So we are not afraid of. So we are just treating them as we would have treated them without any this era of pandemic of COVID.
Thank you, Dr. Agarwal. So, teleconsulting and telehealth is a different topic altogether. And I think more and more rest of the world, people are going to move to telehealth and home monitoring. That is for another video that we won't have time, because I just want to end with a few recommendations for patients. And you mentioned environmental pollution in your paper. I just
Yes,
wanted to draw the attention to the indoor pollution, because in India, people use a lot of agarbatti and room fresheners and car fresheners. My last trip to India in January, I was telling some of my friends, I think I will die from these things more than. So, would you recommend that people reduce their exposure at home as well?
definitely. See, maybe we can talk something about some other chat sometime. These all kind of hydrocarbon based things, they
Yes,
cause lot of alterations in your immune system also,
yes,
right from plastics to your compounds like
right.
room fresheners or car fresheners. So one should not be using them extensively. They should be used judiciously. And any smoky thing, be it a cigarette smoke to your agarbatti or dhoopatti or any other thing, should not be used indoors because it is likely to cause problem to someone who is having some kind of a lung problem, be it an infection or some allergic reaction. So, and I think if you are actually praying, then the God is listening to your prayers without even whatever you are doing for,
Yes.
like do,
I
lighting these
I
agarbattis and
fully
dhoopattis.
agree with you, Dr. Agarwal. God is not really majorly concerned whether you're using an agarbatti at all. It's your thoughts that
Absolutely.
matter, is what I
Absolutely.
always say. And another thing is, again, this is for patients, because
Yes.
one unfortunate thing is, again, I don't know whether it's happening in India. There was a study from the US, I think. Patients got scared when they were on immunosuppressants, and some of them, without asking the doctor, started reducing their medications. This is
Yes.
something I've been telling my patients: do not change your medication dosage or anything without consulting your doctor. Your doctor knows what is going on. So, this is my
Absolutely.
appeal to all the patients: do not self medicate, do not stop, do not change anything. Talk to your doctor. So, Dr. Agarwal is, I'm sure you'll absolutely agree with that. There's nothing new. But this is a
Yes.
very sincere appeal to all the patients. Don't change your medications without your doctor's recommendation. And of course, sleep, eat, move, mind body interventions. These are things we've been talking about for a long time. And Dr. Agarwal, thank you so much. I really appreciate your time with us here today.
Yeah.
And I am going to add your recommendations to the video, and it will be posted on YouTube, and I'll send you a link as well. And
Okay.
thank you very
Just
much.
yeah. Thank you, madam. Just one last line, if you
Yes.
allow me,
Yes, for sure.
to every listener. The best way to boost your immune system is to keep yourself happy, because your serotonin and your dopaminergic system in your brain is actually will be boosted, and it will boost your immune system. Try this out, you will see the results. Thank you.
Thank you, Dr. Agarwal. So to that, I will add that prioritize sleep. That is extremely important. You mentioned natural killer cells, and I had done a separate video on sleep. And one more recommendation I have for people is stop watching the negative news so much. Do you really need that moment-to-moment information?
Absolutely. You can't do anything about it, so why to watch it?
Yes, exactly. So thank you, Dr. Agarwal. Thank you very
Okay.
much.